It's my pleasure to give the opening talk. I think all of you are very familiar with guidelines, and my task was to discuss a very specific topic about who to treat and comparing the different guidelines. These are my disclosures. And before I start, first of all, of course, I'd like to thank Patrick for inspiring me to start the Singapore Hepatology Conference. Some of you have been there. If you have not been to Singapore for the Singapore Hepatology Conference, which is structured very much like the PHC, then please come in 5th to 6th of June. It'll be a nice time for a holiday at that time. Something different we are doing in Singapore, we have a parallel conference called the Science of Hepatitis B Cure, where we will be discussing the scientific and therapeutic aspects of achieving functional cure. So please come to Singapore if you are interested in attending any of these meetings. So let me get back to my topic, which is the global impact of chronic hepatitis B. And we know that more than 2 billion people have been exposed, of which 275 million are living with chronic hepatitis B, and 25 to 40% have cirrhosis or liver cancer. Most of these occur in the liver, in the Asia-Pacific region. And we can see the burden of chronic hepatitis B by WHO regions here. You can see here that most of the infections are in Africa, Southeast Asia, or the Western Pacific region in these blue, pink and light blue colors here. And the treatment eligible also fall into these regions. And we know what the natural history of chronic hepatitis B, that they go through different phases of disease, and a significant minority of patients go through inflammation followed by fibrosis, liver cancer, and early death. However, it's important to note that not all patients end up with end-stage liver disease and HCC. Consequently, should we treat all patients? Since not everyone develops these complications, remembering that the goals of treatment are to prevent cirrhosis, liver failure, liver cancer, and to improve survival. While the endpoints here that guide us towards these things includes things like normalization of ALT, reduction in viral load, e-antigen seroconversion, and S-antigen loss. Some of these, of course, are more difficult to achieve than others. So we must remember that the goals currently in all the guidelines are to reduce liver disease progression. And when we look at elements that contribute to liver disease progression, these are some of the factors: increasing age, family history of HCC, males, particularly more than females, the presence of inflammation or fibrosis, alcohol consumption, hepatitis C genotype, e-antigen status, and elevated viral load. So how do we determine which of these factors are going to guide us towards selection of therapy? And most of this data is obtained from prognostic studies, which are cohort studies. And the characteristics of good studies are a large size, clear entry criteria, being prospective in nature, community-based, well-defined endpoints, few dropouts, sufficient duration follow-up. However, I think if you look at most of the recommendations about quality of evidence, observational study or cohort study actually is not the highest level of evidence. So what can improve the quality of a cohort study? And essentially, you need to go to a systematic review because different cohort studies may have different outcomes and different results. So in larger cohort studies where they show a larger effect size, it may overcome the potential risk of bias of cohort studies. Precision, which can be done by meta-analysis to reduce the confidence intervals, to know exactly how precise that treatment effective, the consistency of effect, low risk of bias, high quality studies, and low heterogeneity can be achieved by systematic review and maybe less so by cohort studies. So no single cohort study is ideal, and the best data comes from systematic reviews. So which brings me to what is a guideline. And guidelines are essentially summaries of evidence intended to assist providers and recipients of healthcare to make informed decisions, and the recommendations may relate to clinical interventions, as we're discussing today, public health activities, or government policies. And I'm going to talk to you about GRADE, because GRADE stands for Grades of Recommendation, Assessment, Development, and Evaluation. Some of you may not have heard about it, but most of you probably have. And this is actually a global movement to develop a common, transparent, and sensible system for grading quality of evidence and the strength of recommendations. And this now is pretty much the global standard. There's an international group of guideline developers from around the world since 2000, and this, you can see the list of these different work groups listed here. And that more than 70 over organizations globally have adopted GRADE, including WHO. I think EASL has also adopted GRADE. So what is the GRADE approach? So I think the GRADE approach is divided into two parts. The top half in light blue is the systematic review, and the bottom part is the guideline development. And actually, it's broken into these two parts because most clinicians are not experts in evaluating evidence. When you do evaluate evidence, you understand that most of this comes from Cochrane groups who are very experienced in developing systematic reviews. So here, they would develop, for instance, formulate questions, such as the PICO questions, and I'll describe what PICO is later on. Look at the importance across the different studies, then create an evidence profile, rate the quality, and this includes reducing risk of bias, inconsistency in directness, and precision publication bias, looking at the effect size and confounders and dose response. And then after this evidence summary has been done, it is passed to the domain expert panel, which are the hepatologists, in this case, where they can grade the quality of evidence based on lowest quality of critical outcomes. And then the panel will then decide on the recommendations for or against, strong or weak, based on quality of evidence, the balance of benefits and effects, values and preferences, and if necessary, also the cost. So that is basically a summary of how GRADE works. And when we look at the different guidelines here, the AASLD, PASL, EASL, and WHO, you can see here that the quality evidence is graded as a high or low. For AASLD, for PASL, high quality, moderate quality, low quality, very low quality. And for EASL, it's divided as to class 1, 2-1, 2-2, 2-3, or 3. And here we can see that the high quality evidence remains with randomized controlled trials. This is in general, of course, but in the situation where we're looking at diagnosis, observational studies is the study design that we need to use. And for WHO, again, high, moderate, low, and very low quality. Initially, RCTs used as high quality evidence, and observational studies are rated as low quality evidence, but may be upgraded depending on the treatment effect and if multiple studies show the same effect. So the strength of recommendation here can be either strong or conditional for AASLD, a PASL again strong and weak. For EASL is strong and weak, and for WHO, strong and conditional. So depending on the wording, essentially there's two types, strong and a weak recommendation. So how were the guidelines developed for the different societies? I think AASLD specific questions were asked, but these were not PICO-based. PASL and EASL, the process was not explicitly stated. And WHO, initial scoping and planning process to formulate questions using PICO format were ranked. And then for the search of evidence, AASLD content experts worked with a systematic review group to synthesize available evidence, and then they developed evidence summaries using the GRADE approach, which is the correct way. Whilst for Apazole and easel, I think most of this were done by the in-house domain experts, where they looked through the evidence themselves and then came up with summaries, evidence-based summaries. And for WHO, systematic reviews and meta-analysis were commissioned by an external group experienced in systematic reviews using the GRADE approach again. Okay, so this is an example of what is a PICO question. PICO questions stands for population, intervention, comparator, and outcome. And here, the question being asked is, amongst S-antigen positive patients, what factors test best identify individuals at highest risk of progression, as well as those at low risk of progression? So this is a question about prognosis. And then in the PICO question 2b, amongst hepatitis B patients, what factors best identify individuals with greatest benefit of treatment and least benefit of treatment in those with and without access to laboratory tests? So, and here the population, they've characterized them here, as well as the interventions in this group. And the interventions here was antiviral treatment. So this is an example of how a PICO question would be formulated. Now, before I actually go into the actual recommendations, I just want to give you a sense of what is the difference between strength of evidence versus strength of recommendations. So, for instance, you can have a weak evidence but a strong recommendation, a situation where evidence is not of high quality but treatment is potentially life-saving. On the other hand, you can have strong evidence but a weak recommendation. A situation occurs where the evidence is high quality, but the benefit may be very marginal, or not cost-effective, or there's potential harm. So there's a difference between evidence and recommendation and the strength of them. So let's go straight into the comparison between the different groups. This is for e-antigen positive chronic hepatitis B. And I've highlighted in red the key ALT and DNA levels, which have been recommended by the different societies. So for SLD, 2 times absolute normal for ALT, and elevated DNA more than 20,000. And in blue is the quality evidence and strength of recommendations. So moderate evidence with strong recommendations. And for Apazole, 20,000 for DNA and ALT 2 times upper limit normal, very similar to the ASLD with a B1 strength of recommendation. Easel, lower levels of DNA and only ALT more than upper limit normal. And for WHO, which I would like to remind you, have done a very thorough job in terms of the systematic review. And they found that abnormal ALT levels and evidence for high-level DNA replication, more than 20,000, regardless of e-antigen status, actually had the best evidence. So they don't even worry about e-antigen status, whether it's E-positive or E-negative. You can see that in the E-negative slide, WHO recommendation is quite consistent, whilst I think for both, all 3 guidelines, ASLD, Apazole, and easel, the DNA levels has been lowered to 2,000 with different levels of ALT cutoff. Moving on to cirrhosis. Here, there's also controversy whether you should have a DNA level cutoff. EASL do not have any DNA cutoff. Any detectable will do, and that's consistent with the WHO one, while Apazole requires more than 2,000. And for ASLD, they also would consider less than 2,000 as a cutoff. For pregnancy, there's no recommendation by the WHO, and you can see the differences in thresholds to start antiviral therapy. Here, ASLD uses 200,000 IU per mil, and so does EASL, while Apazole uses to 6 to 7 log cutoff threshold, much higher levels. For co-infection, for Hep C, the same criteria is used for monoinfection. For hepatitis D co-infection, in the case of hepatitis B, if DNA levels are elevated, you can consider it. And for Apazole, they would like to know which virus is more dominant before treatment. and for easel, ongoing HBV DNA replication by raised HBV DNA levels are recommended. For HIV co-infection, tenofovir is generally recommended across the line, and for the WHO, they recommend ART should be initiated in all those with evidence of severe chronic liver disease, regardless of CD4 count. And this is an instance where there's a strong recommendation, but there's low quality of evidence, for instance. And for children, for ASLD, elevated ALD and measurable DNA levels, a partial moderate to severe activity with any ALT level should be considered. And for EASL, children and adolescents who meet treatment criteria similar to adults. And for WHO, surprisingly, they only recommend it for compensated or decompensated cirrhosis, regardless of ALT levels. For the immune suppressed liver transplant recipients, I think that's fairly clear-cut. Both HBIC and nucleoside analogs are recommended. A partial amongst low-risk patients, HBIC-free regimens can be used alone, and for EASL, HBIC and nucleoside analogs is recommended after transplantation. And EASL has additionally said that donors with evidence of past infection, donors with evidence of past infection at risk of HBV recurrence and should receive antiviral prophylaxis. While for immunosuppressive therapy, I think across the board, everyone recommends antiviral therapy. And there is some controversy about the patients receiving anti-CD20 antibody or stem cell transplantation, rituximab. In most of this situation, they are recommending antiviral therapy as well. Miscellaneous, for acute hepatitis B, it's only recommended if there's acute liver failure, acute fulminant liver failure. Extra hepatic manifestations is recommended to have antiviral therapy if there's active hepatitis B replication, and this could be independent of liver disease severity. And if there's a family history of HCC, this has always been a controversial subject, and this you can consider treatment even if the patient does not fulfill the standard criteria for therapy. So for a partial, they would recommend liver biopsy if the ALT or HBV DNA thresholds are not achieved by this patient, even if they have a family history of HCC. Whilst for EASL, you can consider this treatment if the typical treatment indications are not fulfilled. So what is the future of selection of patients? And I think we should learn something from the cardiologists. This is the Framingham risk calculator. I'm sure you're very familiar with that. A lot of you may be using this in your clinical practice. So we, of course, have developed our own risk calculator, and a lot of this was performed through the REVEAL study, where clearly the levels of high viral load is associated with higher risk of liver cancer. And they have developed a REVEAL risk calculator based on the gender, the age, the family history of liver cancer, alcohol consumption, ALT level, and the HBe antigen status, as well as the DNA level. So the question is, why are we not using the REVEAL risk calculator today? You can see the prognostic risk is based on this risk calculator. Well, first of all, it's unclear whether this applies to Caucasians and non-Asians. The REVEAL population also was above the age of 40, and they're mainly e-antigen negative. And most importantly, treatment benefit had not been demonstrated. So if you treat someone who fulfills the REVEAL risk calculator with a high level score, it's not clear how much benefit they would get, because we have not performed any RCTs or clinical trials showing patients with a high REVEAL risk will benefit regards to clinically significant outcomes such as mortality, liver cancer reduction, and reduction in chronic hepatitis B outcomes. So with that, I'd like to conclude that development of guidelines is now a structured process, with the global standard being GRADE, relying on systematic reviews to provide the highest quality of evidence. The WHO and ASLD have structured scoping questions and systematic reviews in their guidelines. So the task of developing guidelines is not a small matter. It requires an incredible amount of work. And although there are some differences between ASLD, EASL, PASL, and WHO guidelines, in general they are in agreement. And in the future, the use of risk calculators may simplify selection of patients suitable for therapy. However, we must remember that we're in a transition phase because I'm sure you'll hear later today that the goal of the current guidelines is to reduce disease progression and mortality because the likelihood of a cure is low. But this may change with treatments that are better able to achieve functional cure, and in which case all patients could be treated and may supersede then the use of risk calculators. Thank you very much for your attention.